Hi guys, good evening, good evening, good evening. So, welcome to our BLS series, which is continuing on hernia. Today we'll be talking specifically about femoral hernia. We spoke about all the repairs that we do for inguinal hernia in our yesterday's lecture, right? If you guys are good to go, let's start. Hi Mir005, good evening. Hope everybody is doing well. मैं बढ़िया भाई. I think everybody else is also doing good. करें शुरू. Can we start? Can we start? So आज हम बात करेंगे femoral hernia की. Again, a very complex topic. We'll try to understand it in simple form. So we're talking about the femoral hernia. See, the names can be of different sorts, but again the concept remains the same. Hernia is hernia. अब वो femoral canal से निकलेगा. So in order to understand the whole concept of it, let's brush through the anatomy of our femoral canal. So ये क्या है? What is this femoral canal? Now to understand the femoral canal, let's do a simple context here. So let's say if this is the pubic rami, which is going to have the pubic tubercle, this is the pubic symphysis, and this is the rest of the pubic bone that you have, right? Now just for the sake of understanding, we'll just reconstruct it here, and this is how the pubic bone is going to look like. Clear? Now, this is the midline that we're talking about, through which the pubic symphysis is going to pass across. So your pubic symphysis midline is here. Clear? Now we learned yesterday we have something called as the inguinal ligament, right? So it is your external oblique aponeurosis which comes, attaches to the anterior superior iliac spine, goes, attaches to the pubic tubercle. This is your inguinal ligament, right? Beta, all the notes of the BLS series are uploaded on a daily basis. Like, so I also suffer from hernia like but a pilonidal sinus is quite different from a hernia, so you can't mix two things up. No, pilonidal sinus alag hota, hernia alag hota. Let's concentrate here. So this is your external oblique aponeurosis, which has come attached to the anterior superior iliac spine, going into the pubic tubercle. Now once it goes to the pubic tubercle, one second. Okay, once it goes to the pubic tubercle, from the pubic tubercle, it is going to arch backwards, and this backward arching is what we call it as the lacunar ligament. So ये आपका fan shape जो है, इसको आप lacunar ligament बोलोगे, and then it goes and attaches to the pubic rami, and this attachment to the pubic rami is what we call it as the pectineal ligament, or also called as the Cooper's ligament. ठीक है? So same thing, three different names that you will see. That if I just address it across, this is what we call it as the inguinal ligament. This fan shaped structure is what we'll call it as the lacunar ligament, and its continuation is what we call it as the Cooper's ligament. Clear? So I'm just going to label this same thing that we have just learned. This is your inguinal ligament. This is the lacunar ligament. This is your lacunar ligament. And this is your Cooper's ligament. The Cooper's ligament is also called as the pectineal ligament. The other name for the Cooper's ligament is also called as the pectineal ligament. Also referred to as the pectineal ligament, which is here. Okay. Now there is a thin septa which is present here, and this septa is going to bifurcate from the rest of the context. Okay. You made surgery so easy. Love you, sir, from Pakistan. Thank you so much. See, again, I do get a lot of messages, not only from our Indian students, from other part of the world as well. Now that's something as a teacher I would love. Like it's next level thing. I can't express it. Thank you so much for watching our videos across wherever you are. I mean, like, I can only say thank you. And if you have any suggestions, please feel free to push it across as well. Clear? Now, there's a thin septa, and right next to the thin septa, you will see this your femoral vein is present, right? Next to the femoral vein, you have the femoral artery. Next to the femoral vein, you have your femoral artery. Okay, so this is the orientation that you have. Now, this structure which is present, no, like a ring that is present here. There's a ring that is created here, and this is what we call it as the femoral ring. Now, I don't want you to remember them. I don't want to remember the boundaries of the, see, many times they'll ask you, tell me the boundaries of. Santosh sir, good evening. Thank you so much for joining. I mean, we have the legend of our medicine, Dr. Santosh Patil sir. I mean, like, sir, you're watching my video is like, you know, like next level thing. I can't even attribute or, you know, start thanking for that. Like, thank you for all the appreciation. All right. Okay, fine. I'm just getting deviated a bit. Let's stay on topic today. If you have any questions, queries, I'll take at the end of the lecture. Now, here. Now, every time we talk about the boundaries of the femoral ring, students get confused, sir. How do you remember it? What is superior? What is inferior? What is lateral? What is medial? Again, you don't need to do anything. This is what it is. Inguinal ligament comes, attaches to pubic tubercle, turns backwards. That's the story that you have. The superior border will be formed by inguinal ligament, medial boundary will be formed by lacunar ligament, inferior boundary will be formed by Cooper's ligament, and the lateral is going to be formed by the thin septa that is present. That is what your femoral canal is all about. Right, now you will say what next. Now if you know this is the whole concept of it, now you will notice if I just extend it into the lower limb. So you have understood what is the femoral canal is all about. Okay. Now we will replicate the same thing with respect to the human body. Right, so I'm just going to move a little bit down, and let's say we have a patient. Now let's say this is the human body that you have, and this is the lower limb that you have, right? Now, just for sake of understanding, this is your anterior superior iliac spine, this is the pubic tubercle, this is the pubic symphysis, and this happens to be the pubic bone, right? So nothing has changed, everything remains the same, but I want to give you with the human body now, right? Now, this is the groin area that you have, right? Everything is still the same. Nothing I have changed. I'm going to keep it same. I promise I will not alter even a single bit. Just to give you a better perspective, I'm just going to make this part more dominant so that we are able to see. So this is the pubic bone that you have. Which is across here, right? Now, same thing, you have the inguinal ligament which is here, which is turned backwards. As it turns backwards, it is now created into the lacunar ligament which is here. This lacunar ligament will continue to form into Cooper's ligament, and then there is this thin septa that is present. As we have told you, the upper part is the inguinal ligament. This happens to be our lacunar ligament which is medial. Inferiorly it is formed by the Cooper's ligament, and this whole thing that we have just created is basically our femoral ring, right? So this is the femoral ring. Now the thigh is covered by a fascia that is called as the fascia lata, right? Now let's say this is the fascia lata that is covering the thigh. This is the fascia lata that is covering the thigh, and this is the fascia lata which is present here, right? So nothing spectacular about it. So you now know there's a fascia lata which is present, right? Now I hope everybody knows that the fascia lata is the covering that is present on the thigh surface. So this is the fascia lata that we have, right? Nothing spectacular about it. As we've already learned that there are two vessels which are going to be present just next to the septa. One is your femoral vein which is going to be present here. Medially there will be femoral vein, laterally there will be your femoral artery. So these two structures are present as it is. Now you will see that there is a vein that is going to travel on the medial aspect of the lower limb. If you really want to know from where exactly this is traveling, so this is the orientation that you have of the lower limb. So let's say this is the thigh region, and let's say this is the knee part that you have. If I continue this across, so let's say This goes across here, and this is the calf region. This is the calf region, and this happens to be the lower limb. This is the medial malleus that you have. You notice there is a vein that is going to run from the medial malleus on the medial aspect, and then it is going to continue. Now the vein that is going to go all through this is your great saphenous vein, right? Now this great saphenous vein, as it continues, it turns medially, and there is a defect in the fascia lata. Now that defect in the fascia lata is the defect where your great saphenous vein is going to enter into deep compartment, and then it is going to go. You see the femoral vein is running in the deep compartment. So this is where the femoral vein is running, right? This is the orientation of the femoral vein, because femoral vein is present in the deep compartment. You see this great saphenous vein is going to go through the defect in the fascia lata, and then it opens into the femoral vein. So the great saphenous vein opens into your femoral vein. So this opening that is present in the fascia lata is actually an opening or a gateway for your great saphenous vein to enter and then open into your common femoral vein, right? This is what we call a saphenofemoral junction. Our job is done. But if you look carefully, this opening that is present in the fascia lata, this is what we call it as the saphenous ring. This is what we call it as saphenous ring. We call this saphenous ring because the great saphenous vein is entering through this, and this upper part is what we call it as the femoral ring. This is what we call it as the femoral ring. This is your femoral ring, right? Now the passage between the femoral ring and the saphenous ring is what we call it as the femoral canal. So this is what we call it as the femoral canal. So femoral canal is anywhere between 1.5 to 2 centimeters in length. It is anywhere between 1.5 to 2 centimeters in length. It is not actually a true canal. It's a small passage between the femoral ring and your saphenous ring. Is that clear? So that is how your femoral canal is formed. Absolutely simple. There is nothing spectacular about it. It's a small orientation about the femoral canal that has been present across here. Now this vessel that is traveling here, I hope everybody knows it. This is your great saphenous vein. This is your great saphenous vein. This happens to be your common femoral vein. This happens to be your common femoral vein which is present here. And this junction that you see, this is what we call it as the saphenofemoral junction. So when we talk about varicose veins, I'll be talking a lot about the SFJ competencies as SFJ components. So this entry point where the great saphenous vein is opening into the common femoral vein is called as the saphenofemoral junction. So this small passage is what we call it as femoral canal. Nothing spectacular about it. Now, you know, they'll keep asking you what is the relationship of the pubic tubercle with that of the saphenous ring. Now when you look down, you will find that from the pubic tubercle you have to come down, and then you have to go a little bit lateral, right? So this is where your femoral ring or your saphenous ring is going to be present. So it is 4 centimeters below and lateral. It is 4 centimeters below and lateral to pubic tubercle is where you get your saphenous ring. Is where you get your saphenous ring. Okay? Clear, guys? Until now it is clear? Quick feedback. Clear? Okay. I'm just accessing the chat box. Just give me 1 second. Okay. So the location of the femoral ring is going to be 4 centimeters. If I have to give you the exact location, it is found 4 centimeters below and lateral to pubic tubercle. It is 4 centimeters below and lateral to pubic tubercle. It is 4 centimeter lateral and below to pubic tubercle. As simple as that. Khatam. Okay. Now what is your femoral hernia? Now you have understood the femoral ring, you have understood the femoral canal. So if I have to simply say the anatomy of the femoral ring or the femoral canal, so you will say that this is going to be your femoral ring. This happens to be your saphenous ring. The passage between these two is what we call it as the femoral canal, right? Now let's see if you can answer me this. This is the medial side, this is the lateral side, right? Just for the sake of understanding. So when you look at the entire component, I can divide them into the superior boundary, I can divide them into the medial boundary, I can divide them into the inferior boundary, and then I can obviously divide them into lateral boundary, right? So when you see all this, the superior boundary of the femoral ring is formed by the inguinal ligament. It is formed by the inguinal ligament. When you look at the medial boundary, it is formed by the lacunar ligament. It is formed by the lacunar ligament. When you look at the inferior boundary, this is formed by your Cooper's ligament. This is your Cooper's ligament. And when you look at the lateral boundary, it is formed by a thin fibrous septa. Now this thin fibrous septa will have femoral vein. Just for the sake of understanding, I'm just going to draw it here. There'll be a femoral vein. There'll be femoral vein which is going to be right next to here. So this is the femoral vein which is going to be right next to it. Okay? So this is the orientation that you have. Now, what is a femoral hernia? The femoral hernia is the content that enters from the femoral canal and exits from the saphenous ring or the saphenous opening. So this is what we call it as the saphenous ring. So unlike your inguinal hernias, you don't have direct, indirect, all that nonsense is not there. Simple सी story है, आपके femoral ring से content गया और it has now gone into your saphenous ring. As simple as that, nothing more spectacular about it. Clear है? ठीक है? So femoral hernia, again if you look at the end, again like we did in inguinal hernias, if I ask you following questions, what is the entry point of the femoral hernia? What is the exit of the femoral hernia? What is the sac made up of? And what is usually the content of the femoral hernia? These are the questions that you will have. Now when you talk about the entry of the femoral hernia, it is going to be from the femoral ring, no question. Exit कहाँ से बनेगा? Exit बनेगा saphenous ring से. It is going to be the saphenous ring. The sac is usually formed by peritoneum. The content is usually bowel or omentum. One thing that you have to remember, that the possibility or the probability of the bowel strangulation is much more higher in femoral hernia. So as a note point before we move down, as a note point you can say that there is increased risk for bowel strangulation. There is an increased risk for bowel strangulation that can occur in femoral hernia. That's how simple and component that you have. Now let's talk about how does a patient of femoral hernia is going to present to you. We'll talk about the clinical presentation or the clinical features of the patient presenting to you with femoral hernia. Now when you talk about the femoral hernia, the femoral hernias are usually more common. It is more common in females when compared to males. It is more common in females when compared to males, right? They will also have the same presentation. There will be presence of an inguinoscrotal swelling. They're also presented with inguinoscrotal swelling. Usually the swelling is below the inguinal ligament, right? So swelling is below inguinal ligament. Right, so the swelling that you see, it is usually below the level of the inguinal ligament. The same thing is there. There will be positive cough impulse. See, I don't need to go and tell you all this, but again, for every hernia, it is positive. So you will have positive cough impulse. It will not be there if it is strangulated. Strangulated will be associated pain. We have a separate video for hernia complications or a complicated hernia presentation that we have a separate component about it. Now we're talking about simple hernias. Okay? So inguinoscrotal swelling, swelling below the inguinal ligament is present. The cough impulse is present. It is reducible. This is going to be reducible as well, right? So this is how usually it is going to present to you. You do the basic investigation. Now one thing that I want to bring your basic notice is the differential diagnosis in femoral hernia. So especially when you're attending your Viva, no, this is a very popular question that they'll ask you. What are the DDs that you can give me for femoral hernia? Number one, the most common DD for a femoral hernia is going to be an inguinal hernia. It is going to be your inguinal hernia. Along with that, it can also be an enlarged lymph nodes. There's a lymph node that is present inside the femoral canal, and that is called as the Lockwood lymph node, right? So lymph node which is present inside, if I go to the femoral canal, there's a lymph node that is present. The lymph node that is present inside the femoral canal, this is what we call it as the Lockwood group of lymph node, or the Lockwood lymph node. This is what we call as a Lockwood lymph node. A lymph node that is present inside the femoral canal. In fact, the content of the femoral canal, when we talk about it, no, it is the Lockwood lymph node that is present, right? So it could be an enlarged lymph node as well. Now there's something called as the saphenous varix. Now saphenous varix is usually seen in your varicose vein. So normally what happens is, because there is saphenofemoral junction, valve becomes incompetent. When the patient is going to cough, there'll be a positive cough impulse at the SFJ junction, mimicking as hernia, but is actually not a hernia, right? So that is what we call it as the saphenous varix. Then a vascular aneurysm, usually it is the femoral artery aneurysm. It is the femoral artery aneurysm, secondary to a psoas abscess. It can be secondary to a psoas abscess also. And then you have the muscle that can cause a hematoma and mimic the femoral hernia is the rupture. It is going to be the rupture of adductor, that is adductor longus with hematoma. Longus with hematoma, right? So these are the ones that are going to present to you with the DDs of femoral hernia. Now when you know all the DDs of femoral hernia, the presentation is there. Now we'll talk about the repairs, right? So femoral hernia repair, again same, everything is same. So our concentration will be here for the femoral hernia repair. So when you talk about the femoral hernia repairs, in a femoral hernia repair, we have three techniques, right? So the first technique is going to be what we call it as the Lockwood surgery. The first one is what we call it as the Lockwood surgery. The second one is what we call it as the Lotheissen surgery. And the third technique, which is going to be for emergency, is going to be MedEd surgery. So three surgical techniques that you have. Number one is going to be Lockwood. Number two is going to be Lotheissen. And number three is going to be MedEd. Remember, Lockwood and Lotheissen is performed for uncomplicated femoral hernias. So there are techniques that I'll be using for uncomplicated. I'll be using for uncomplicated femoral hernias. Now, whenever you're suspecting a complicated femoral hernia, that is for obstructed or strangulated femoral hernia, or a strangulated femoral hernia, I'll be using the MedEd technique. I'll be using the MedEd technique, right? So when you talk about the approaches, remember when we say a Lockwood approach, the Lockwood is actually a low approach or a low inguinal approach. It's a low inguinal approach. Lotheissen is actually an inguinal approach. It is an inguinal approach. And MedEd is what we call it as the high inguinal approach. It is a high inguinal approach, right? So we have three standard approaches that you have. You have the low inguinal approach, you have the inguinal approach, and then you have the high inguinal approach. Remember, MedEd is usually used whenever you have an obstructed or a strangulated femoral hernia. It's going to be in that context, right? Sir, white color background. Bit of white color background. We tried white color background before also, but certain colors were not very predominantly seen. तो वो screen पे ना थोड़ा blur आ रहा था. To overcome that, we have switched to a black background. Okay. Now, can we? Yeah, I know. I see. I can't cater to everybody's their own preferences, but I hope everybody understood this. Okay. So let's understand what do you mean by this. जो जितना भी अभी ये approach what you have done, we'll try to summarize that. Now, imagine that this is the representation of the patient. This is the medial aspect that you have, and let's say we are saying this is the inguinal ligament. This is the inguinal ligament that we have. Now, three approaches that you have. One, if you go from here, this is what we call it as low inguinal. One, that you're going parallel to the inguinal ligament. This is your approach number 2. So it is a different color. So this is your approach number 2. And the MedEd, which is your third approach, this is going to be your approach number 3. This is your MedEd that is present, right? So this is your MedEd incision. This is your MedEd incision. This is your Lotheissen incision. And this happens to be your Lockwood's incision. Okay. So 3 incision, okay. If you are going below the inguinal ligament, that is low inguinal, it is Lockwood. If you are going along with this is called as Lotheissen. And if you go like a paramedian incision, this is your MedEd. Again, the repairs are quite simple. You are not going to, really break your head against it. We'll try to understand each one of them as we talk about it, right? Now, what you're going to do is we'll talk about the Lockwood's approach first. So we said Lockwood's approach is actually a low inguinal approach. It is a low inguinal approach. Now, what we're going to do in a Lockwood's approach or a low inguinal approach is we'll try to gain the axis as we could see across. Okay? Now, gaining the axis is quite simple. Let's say this is the region that we're talking about. So let's say just to get the things in that context, we have the anterior superior iliac spine, which is here, and it goes across here. This is the pubic tubercle, this is the pubic symphysis, and this is the pubic bone that you have, right? And this is the inguinal ligament that you have. So this is the inguinal ligament that you have put across it. We know the femoral ring is here, right? This is the area of the femoral ring. You will notice whatever content is going to move, it is going to move from behind this, enter into the femoral ring. There is the saphenous ring which is present here. So this is the saphenous ring. Now, whatever content has gone inside will travel through the femoral canal, or I can say it goes behind the pubic arch, and then it is going to pop out like this, right? So this is what your femoral hernia is going to be. Now this part is an extension of your peritoneum only. So obviously the peritoneum is going to come, and this is the exact component that is going to come. So your Lockwood says that we are going to make an incision right exactly where you have the swelling. So this is where I'm going to make a transverse incision, right? This is where I'm going to make a transverse incision. This is your Lockwood's incision. You will open up, you will reduce the sac back into the femoral canal, right? So Lockwood says make an incision, make a transverse incision over the swelling. The first step is to make a transverse incision over the swelling, right? Now, once you have done that, you are now going to reduce the hernia. Reducing the hernia basically means to push this sac. So I'm going to push this sac back in. So I'm going to push it back. It goes back into the abdomen. So I'm going to reduce the hernia, right? It is going to be reduce the hernia. Now what I'm going to do is I am going to suture the inguinal ligament. I'm going to suture the inguinal ligament with Cooper's ligament. And if you do that, your Lockwood repair is done. Now, what have you achieved by doing this? Let's try to understand this. So you have the pubic rami, which is present here. This is the pubic tubercle. This is the pubic symphysis. And this happens to be the pubic bone, right? So nothing spectacular about it. My job is to prevent the hernia from going forward, right? So can I ask you a doubt for the thyroid series? Suyesh, you can post your doubt. Once we're done with the femoral hernia, I will definitely address your doubt on the thyroid. Okay? Now coming back here. So this was our inguinal ligament which was going here. Okay? And we said it is going to turn backwards. This is what our lacunar ligament is here. And this is your Cooper's ligament. And there was a thin septa which is present. Correct? यही हमने बात हुई थी. ये आपकी inguinal ligament हो गया. This happens to be your lacunar ligament. And this happens to be your Cooper's ligament. Okay? Now, if you see very carefully, where is the entry point of the hernia? Entry point of the hernia is here. Right? What is this entry point? When you look at this entry point, this was the entry point. Now, what is this entry point? That entry point is nothing but the femoral canal or the femoral ring. If I obliterate the femoral ring, entry point ही बंद हो गया ना. अगर entry point बंद हो गया, उसका हरने तो बनेगा नहीं. तो बोलता है Lockwood एक काम करते हैं, एक suture लेते हैं, ठीक है? We'll take a suture, right? I said great. We'll take a suture and then we'll suture this inguinal ligament to the Cooper's ligament. बात ही खत्म. आपने block ही कर दिया. If you have blocked, if you have sutured the inguinal ligament to the Cooper's ligament, entry point ही blocked, entry point blocked है, उसके बाद तो hernia बनेगा ही नहीं. So this was one of the good repairs that we had. In fact, it is the most simplest repair for the femoral hernia to be done. So here you have simply went and you have sutured the inguinal ligament. You have sutured the inguinal ligament to that of the Cooper's ligament. आपने inguinal ligament को you have sutured it to the Cooper's ligament, दोनों के बीच में obliterate ही कर दिया. ना बजेगी बांसुरी, खत्म कहानी. ठीक है? So this is what your Lockwood repair is. आई बात समझ में? Clear है? Guys, I want the chat box to be a bit buzzing because all these concepts are important. लगता आसान है, बना रहा हूं इसलिए दिख रहा है. You are able to visualize it as I'm able to draw. If you don't acknowledge it, I don't know whether I and me, like we both are on the same page. I have done these surgeries on a regular basis, so I have the orientation. So with that orientation, I'm able to draw and give you that picture. But is it receiving you in a proper way is a bigger question. Clear? If you're clear, let's go to our next approach. The next approach that we have is the Lotheissen approach. Now, when you talk about the Lotheissen approach, it is what we call it as the inguinal approach. This is what we call it as an inguinal approach. Okay? Now, what is this inguinal approach? What is the Lotheissen approach? In simple words, no, so that we all understand it, it is similar. It is similar to Lichtenstein, or also called as the Bassini. दो repairs है, Lichtenstein or the Bassini's repair. So it is similar to that of a Lichtenstein or the Bassini's repair. Like we have done, in the same context, if I have to repeat these steps, here I will take an inguinal incision. I will take the inguinal incision, identify the external oblique aponeurosis. I will open the external oblique aponeurosis. I will mobilize the cord, exposing the fascia transversalis. I'm going to open the fascia transversalis. I'm going to open the fascia transversalis and then enter. So once you open the fascia transversalis, you reach the space between the peritoneum. So this is your pre-peritoneal space. So see, pre-peritoneal space is accessed. The pre-peritoneal space is going to be accessed. So once you access the pre-peritoneal space, I'm going to reduce the hernia. I'm going to reduce the hernia. Now once you have reduced the hernia, either you are going to suture or you're going to put a mesh plug. So either you can put a mesh plug or you can suture the defect. And rest is like inguinal hernia. Rest of the repair is like inguinal hernia. The rest of the repair is like inguinal hernia. I've written all these steps. Let's understand what is this. So you're saying an inguinal incision is there, opening the external obliquoponeurosis, mobilizing the cord, opening the fascia transversalis, then accessing the periperitoneal space, reducing the hernia, put a mesh plug, suture, and then repair the rest of it. Now, what do you mean by this, right? Again, we'll take the same component, right? So you have the patient. So this is what you have. This is your anterior superior iliac spine. This is your pubic tubercle. This is your pubic symphysis. This happens to be your pubic bone. So as you have the pubic bone here, this is going to run across in the same context, and then it is going to come across here, right? We have the same context here. This is your inguinal ligament that you have. This is your superficial inguinal ring. We'll recreate every single thing that we have learned, but in a very, component manner, so that we all are in the same page. Okay, lacunar ligament, Cooper's ligament, thin septa, femoral canal, everything is there. Now, when you go deeper, we all know that the innermost part that you have is going to be your deep inguinal ring, which is here. This is the fascia transversalis that you have. Behind the fascia transversalis, you have the peritoneum, which is going to be present here, and there's a pre-peritoneal space. So how do you know there's a pre-peritoneal space? You see there's a fatty tissue which is present here. So between the peritoneum and the fascia transversalis, you will have this fat, and this fat is what we call it as the pre-peritoneal pad of fat. I'm not interested. I'm just going to skip it off. Okay. Now, where is the hernia coming from? Now, the hernia from the peritoneal surface. Just understand, it is not going to the inguinal region. Now this peritoneum that is present, this peritoneum is now going to sink in. As it sinks in, it is going behind the femoral canal. So behind the inguinal canal, entering into the femoral canal, it is going to travel all the way across here. And here you have your saphenous ring which is present. Through the saphenous ring, it is now going to pop out. This is what your femoral hernia is. Okay? This is what your femoral hernia is. So nothing spectacular about it. Everything remains the same, just the orientation. This is the peritoneum. It is going behind the inguinal canal, entering into the femoral ring, going through the femoral canal, coming out from the saphenous ring, and the hernia is popped out. Now what I'm going to do is, I have decided that I'm going to operate, right? So Lotheissen says we will make an incision over the inguinal canal. So this is my line of incision over the inguinal canal. So as I've made my incision, or I'll make it more precise in my incision, let's say I have made my incision like this. So this is the incision that I've made. Now once I've made the incision, I have opened the inguinal canal. So we all know the inguinal canal is made up of, as you can see on the anterior surface, I can say that it is made up of your external oblique aponeurosis. So I'm going to open up the external oblique aponeurosis. Now the minute I open up the external oblique aponeurosis, this is how I have opened the external oblique aponeurosis. The minute I open the external oblique aponeurosis, you have the cord structure, no, the vas difference and all. Let's bring that cord out. So I've just, so this is the cord, I have just mobilized the cord. Now this is how the cord is going. I've just mobilized the cord because the cord is going to go through this area, right? I've pulled the cord out. Once I pull the cord out, I have now exposed your fascia transversalis. ठीक है, तो ये आपका fascia transversalis है, posterior surface पे present है. I have opened the inguinal canal the minute I see it. So this is, again, for the sake of understanding, do not get confused. This is your fascia transversalis. This is your external oblique aponeurosis. This happens to be your peritoneum. Nothing has changed. ठीक है. Now, I have opened the external oblique aponeurosis. I have exposed the fascia transversalis. Now I am going to incise the fascia transversalis also. Now the minute I incise the fascia transversalis also, I have gained access to this area. Now this area is where you have, this is all covered by your peritoneum. So this is all covered by your peritoneum. This is the peritoneal surface that you have. So this is all peritoneum that is there. So the minute I open this, the minute I open the fascia transversalis, so this is where I've dissected the fascia. I've opened the fascia transversalis all the way to your deep ring. I've opened the fascia transversalis all the way to the deep ring. Now, as I open all the way to the deep ring, what am I going to see? I'm going to see on the posterior mode surface, you have the peritoneum. So this is the peritoneum that is present. Now, where do I see? I see this peritoneum is going here. So this is where the peritoneum is sinking down because it is carrying the content. ठीक है. Now once I've gone access, so पीछे जाके peritoneum पे access मिल गया, I'm going to pull the peritoneum back. So what I'm going to do is I'm going to hold this peritoneum and I'm going to pull it back. Now as I pull it back, you see the entire content is going to move up. Now as it moves up, the hernia is now going to be reduced. Now, once the hernia is reduced, same thing, you're going to repair the posterior wall. Now, as you repair the posterior wall, again, see, Basini's, you remember, the fascia transversalis was tucked. So, two leaflets of the fascia transversalis were created. Now, this is the upper leaf of the fascia transversalis. This is the lower leaf of the fascia transversalis. Once you have reduced it, what I'll do is I will take the lower leaf and then I will suture it to the upper leaf, and then I will bring the upper leaf and I will suture it to the lower leaf. So, this is how you're strengthened your posterior wall, like Basini's repair. So that is why I told, no, it is also like similar to the Basini's repair. कल हमने पढ़ा था Basini's में यही करते ना, fascia transversalis का जो lower leaf है वो upper leaf में टक कर दिया, upper leaf को lower leaf के साथ जोड़ दिया. Now it has got a full wall. So you have reduced it. Another thing that you will also do is what you did in your Lockwood's approach, I am going to obliterate. So I'm going to suture this femoral ring as well, because I've got the access, no, pieces access मिल गया, femoral ring को suture कर दिया, this is done. So this is what we call it as the Lotheissen approach. ठीक है. So two approaches for femoral hernia, दोनों important है. One, a very simple basic one that I told you is a Lockwood approach. बच्चा भी कर लेगा Lockwood. अगर मैं आपसे अभी कराऊंगा femoral hernia की सर्जरी Lockwood की ना, आप बोलोगे सर hernia इतना simple है, incision दिया, reduce किया, inguinal ligament को Cooper's ligament के साथ suture किया, बात खत्म. When you come back to your Lotheissen approach, उसको inguinal hernia की तरह करेंगे, लेकिन हम fascia transversalis भी खोल देंगे. खोलने के बाद hernia reduce करेंगे, फिर under tuck करेंगे, over tuck करेंगे, Basini's की तरह reinforce करेंगे, mesh लगाएंगे, Lotheissen Lotheissen की तरह और बाहर आ जाएंगे. ठीक है. So Basini's की तरह wall strengthening करेंगे और Lotheissen की तरह mesh लगाएंगे, and then you're back. And this is how you do your Lotheissen approach. And this is all about the femoral hernia. So psoas and femoral hernia direction different. But a psoas muscle, when you have a psoas abscess specifically, it is more posterior. But then when the abscess sinks in, it collects in the inguinal region. So that can mimic as the hernial component there. So it can be for a differential diagnosis for both your inguinal and femoral, but psoas abscess में pain भी होगा, especially on flexion of the hip. ठीक है. So again, when you talk about psoas abscess in our pyonephric, renal tuberculosis, pyonephric abscess and all, वहाँ पे और detail में discuss करेंगे. ठीक है. So this is all that you should know in the context of femoral hernia. I wanted to know what is this femoral canal. इसमें इतना फालतू में हवा क्यों बना के रखा, कुछ नहीं है बेटा, यही आपका femoral canal है. If you understand this representation, every single thing is going to be a piece cake, right? Sorry, क्या बोलते हैं, cake walk. Clear? Now if you have any questions, fire it away. कोई सवाल, कोई शक, कुछ अगर कोई सवाल, कोई शक नहीं है, you know where to ask us more questions. Reach us on the Telegram as well as on Instagram. This is called as the surgery guy. Any questions, any queries, you can just write it down here. It is by my name, that is Dr. Sandeep Seeram Reddy. ठीक है? So any questions, any queries, write us here. ठीक है? So that's it for today from my end. If you have any questions, somebody wanted to ask a question from thyroid. If you're still there, better fire the question. Let's see. Let's see, you can put me in a spot. ऐसा कोई सवाल कि मैं ना जवाब दे सकूं. I might not know, but I'll try. चलो, कोई सवाल नहीं, मतलब या तो आपको कुछ समझ में नहीं आया या तो मैंने बहुत सुपर पढ़ा है. ठीक है, तो I'll take the second one as a closing argument. Until then, see you tomorrow with another hernia and with more intrigued concepts. ठीक है, चलो. सुयश, नो सर, इट्स एन इजी क्वेश्चन. पूछ लो बेटा, सवाल क्या है? Differential diagnosis of normal T3, normal T4 and normal TSH apart from euthyroid goiter. You're asking if there is a thyroid swelling with a normal T3, with a normal T4 and normal TSH. It can be in your malignancies also. No? Thyroid cancers will also present to you with a euthyroid status. Yeah, thyroid cancers can also present to you with euthyroid status. But a goiter में ना, you can never have a normal TSH. अगर T3, T4 normal है, so normally what happens is a compensation that is going on, no? Goiter में. In a compensatory factor, when there is, you know, less amount of T3, T4 produced, compensatory mechanism से TSH increase करेगा, that TSH will try to compensate by causing hypertrophy, hyperplasia, तो TSH में थोड़ा बढ़ाव मिलता है. It could be thyroid malignancies also, where you can have a normal T3, T4, TSH values with a thyroid swelling presenting to you. Could be a thyroid malignancies also. देखो, inflammatory thyroid swellings में you cannot have a normal T3, T4, TSH because Hashimoto's and Riedl's will have a hypothyroid status. Decurrence initially is hyper, eventually it is hypo. Toxic mein it is going to be hyper only. So the only other swellings that can have a euthyroid-like picture other than goiter is going to be malignancies. Like I can say thyroid lymphomas also, but thyroid malignancies. I think that answers your question, Shuas. Okay, chalo. Thank you so much. Good night. See you tomorrow. Bye bye.